Welcome to this i3 Health Additional Advances interview. Today, we are joined by Dr. Julia Rotow, who recently chaired the educational activity with us, What's New with HER2, Charting New Paths in NSCLC Care. In this interview, we will discuss updates and advances for HER2 and NSCLC treatment landscape since recording. Thank you for being with us today, Dr. Rotow. We really appreciate it. Would you like to begin with an introduction of yourself and what you do?
Yeah, it's great to get to chat with you again. And this has certainly been a fast moving area where you have ongoing, I think, advancements in the options that are going to be available for patients with HER2-driven non-small cell lung cancer. Just exciting as this is a relatively new actionable target for this in this particular patient population. I'm Julia Rotow. I am a thoracic medical oncologist at the Dana-Farber Cancer Institute, where I'm our clinical director and research director, and additionally do work in oncogene-driven non-small cell lung cancer.
Terrific. Yeah, we're definitely excited to talk to you today. So, to begin, would you like to talk about, since recording, have there been any updates or advancements for HER2 and NSCLC treatment?
Yeah, so since the end of last year, some of the major changes, or we hope changes, have included ongoing availability of increased data about the role of HER2 tyrosine kinase inhibitors for management of HER2 mutant non-small cell lung cancer. HER2 as a driver mutation in lung cancer has been unusual in that we have two major classes of therapies which have shown activity. We have HER2-directed antibody-drug conjugates, HER2 ADCs, notably trastuzumab deruxtecan, which is approved in the FDA for previously treated HER2 mutant lung cancer, as well as HER2 tyrosine kinase inhibitors. These are oral small molecule inhibitors, in many ways more analogous to the sorts of targeted therapies we use for many oncogene driver mutations in lung cancer. Now, these are not yet approved by the FDA, so we don't yet have a standard of care option. These are just accessible through clinical trials, but we continue, including in the last 6 months, to see new data being presented, helping to characterize their safety and efficacy profile for this patient population.
Terrific. It seems like there's a lot of exciting things happening and a lot of things to talk about. So, I wanted to ask you, why are HER2 mutations significant in NSCLC, and what are their implications for treatment planning?
Yeah, so in non-small cell lung cancer, we have an ever-expanding list of actionable therapeutic targets, which lend themselves to more personalized forms of therapy beyond, say, standard immunotherapy or standard chemoimmunotherapy in a frontline setting. HER2 mutations are one of these actionable drivers. They're found in a few percent of lung adenocarcinoma, and especially as we see the increasing availability of active and well-tolerated overall agents emerging to treat these mutations, all the more important to be sure that these are being captured. It's particularly relevant in lung cancer because these are a newer driver in the last few years. There are going to be patients who had their genomic profiling done in a more limited fashion several years ago when it would have been comprehensive. But of course, now with the emergence of these and other novel therapeutic agents, that profiling is no longer comprehensive by modern standards. So this is one of those mutations that occasionally does get missed. And it's absolutely reasonable for treating a patient thinking about next line therapy, making sure to look back and just double check, was their original genomic profiling and biomarker profiling more broadly comprehensive by modern standards? If not, try to fill those gaps with supplementary testing.
Kind of going back to updates and stuff specifically for HER2 mutations, have there been any updates from ongoing trials that you would like to highlight that are working on better understanding this treatment landscape?
Yeah, and I think the newest data has been coming out in the last few months between AACR in April and ASCO just this past June. We saw updated data both for zongertinib and for VER-292, or cevabertinib now has a name, showing updated efficacy safety data for HER2 mutant patient populations. So I was going to summarize that here. So at AACR and now in New England Journal published as well, we saw data for zongertinib. This is a selective HER2 inhibitor, so it's relatively EGFR sparing. It's not an EGFR exon 20 inhibitor, and therefore hopefully was going to be able to spare some of the EGFR wild type toxicities that we've often associated with attempting to target HER2 mutations and HER2 exon 20 insertion mutations. So relatively sparing diarrhea and rash compared to some other options which have been in development. And this showed some updated efficacy data broken down by class of HER2 mutations at AACR. And I think notably showed an overall response rate of just over 70%, 71%, disease control rate of 96%, These are the kind of numbers we want when we're talking about potent selective TKI-based treatments in lung cancer. Now, HER2 mutations are interesting in that they are more heterogeneous than some of the actionable mutation targets that we look at in lung cancer. So we have mutations that are located within the tyrosine kinase domain, so the business end of the HER2 protein, so to speak. But there are also mutations that you'll see scattered across other components of the protein, which may be activating in other ways. We call them non-TKD or non-tyrosine kinase domain mutations. So the repeated trend with the emerging HER2 inhibitors, which are becoming, having increasing available clinical data and trials, has been higher response rates for those with tyrosine kinase domain TKD domain mutations than in other settings. So if you look, for example, at zongertinib's data, if you look outside the tyrosine kinase domain, response rate does drop. It went down to 30% for these other little less common HER2 mutations. So still clinically active, but not quite as high a response rate as in the kinase domain. Another important question has been, well, how will the activity of targeted therapies in this space be in patients who've received not just platinum doublet-based chemotherapy regimens, but also prior HER2 antibody drug conjugates, because these patients will, as part of standard of care treatment, currently have been receiving chemo or chemoimmunotherapy, then an ADC with trastuzumab deruxtecan, and now they might be receiving these TKIs as they become available. And here, as you might expect, response rates are a little more modest after these more heavily pretreated patients. So in the AACR update for zongertinib, response rate of 48% in patients who'd had not just chemo, but also a HER2 ADC. So not completely overlapping resistance, but a little more modest response. So that's something I think we're going to have to continue to watch as we see these areas where there are multiple different therapeutic classes all working on the same target in different ways. Now, the other big update we saw in the last few months for HER2 targeted therapies was also the updated data from sevabertinib. So that's the Bayer 292 compound was its other name previously. And here again, this was for patients who are previously treated and was broken down by tyrosine kinase domain and non-tyrosine kinase domain mutation. And here the response rates were all around 60%. Actually across many of these cohorts, a little better for the kinase domain mutations, maybe a little better for a small first-line cohort. So again, meaningful clinical activity, I think useful for our patients to have these agents available. Now, Bayer 292 is both an EGFR and a HER2 inhibitor, so there is a little more diarrhea and rash, as we might expect for an agent that's hitting both of these targets. That is a difference, I think, looking cross-trial in the toxicity profiles of these two studies. So I think more to come, and I think none of these agents are available yet in clinical practice. We certainly hope they will be. I think they'll be a useful tool for our patients.
Definitely. Well, first, thank you so much for such an in-depth and incredible overview of what we're all looking forward to and what you're researching right now. So with all this information and studies that are going on right now, in your opinion, why would it be important for clinicians to participate in educational activities like this one that you just shared to better understand the importance of HER2-directed therapies in the NSCLC treatment space?
I think in general, just in oncology as a whole, we're facing the challenge of staying up to date with the immense amount of information that's coming in all directions. And I work a subspecialist in lung cancer, and even that area, the amount of new data to integrate into optimal clinical practice can be overwhelming. And when you add in covering all other forms of solid tumor, even hematologic malignancies, certainly these sorts of programs that can condense and provide a Reader's Digest version of what are the key updates, I think are really helpful to all of us in clinical practice.
Definitely. And I know you were talking a bit about the targeted TKIs, and I just wanted to ask if you had any expectations or what you're looking forward to that might become a standard of care.
Yeah, and of course, this is my opinion and a little bit of speculation, but I think based on the strength of the data we're seeing, looking at cross-trial comparisons, I absolutely do expect that we're going to see a HER2 TKI, assuming there's FDA approval, become our new standard of care, at least in patients who've had prior platinum-based chemotherapy in HER2 mutant lung cancer. I think I will highlight the zongertinib data has been very compelling. I think we're all hoping this is going to receive FDA approval, and we'll be looking forward to having this available as a tool for our patients. And again, with the response rate 70%, PFS a little over a year, I think that's going to become a very compelling option, particularly when you add the convenience of an oral therapeutic that the patient can receive at home is always something that's attractive both to the patients and physicians. And the bigger question will be, are we going to be using HER2-directed therapies in the frontline setting? All of these trials I just talked about were for previously treated patients. So, and that was defined as prior platinum doublet-based chemotherapy. But there are actually 3 key frontline trials going on looking at comparing HER2-directed treatments to chemoimmunotherapy. So there's a study comparing trastuzumab deruxtecan and ADC to chemoimmunotherapy, the DESTINY-Lung04 trial in the first-line setting. There's the BEAMIUM-Lung2 trial comparing the first-line zongertinib to chemoimmunotherapy. There's SOHO-2 comparing first-line Bayer, the sevabertinib to chemoimmunotherapy. So these may help us to better define what is the extent of what I hope will be advantage in the frontline setting to a directed therapy. And frankly, I think with the strength of the data of the TKI is that we're going to see a lot of off-label frontline use, simply weighing quality of life and relative efficacy data that we've seen with chemoimmunotherapy. That will, of course, will depend upon risk-benefit discussions between patients and the other individual physicians.
Awesome. I mean, you've given us a lot to look forward to and think about. So I really appreciate you taking the time to explain all this for me and for our listeners. So I just wanted to ask, as a final question in conclusion, are there any other messages or information that for those listening that you would like to share in regard to the importance of these educational opportunities, or just more of what you're looking forward to in this treatment landscape?
Yeah, I think the one last message I'll leave everyone with, apart from the critical nature and increasingly critical nature of comprehensive biomarker profiling in lung cancer, but I'll just emphasize that all these things I just spoke about, they're available in clinical trials, not through standard of care. And that's why I always encourage both patients and physicians to be thinking about not just standard of care options, but is there going to be a way for a patient who might be interested to access clinical trials? And I would emphasize that I know any center that runs trials is always really excited and happy to see patients to talk about all available potential options and help people access whatever might be the right treatment for them.
Thank you so much for your time today, for educating us and updating us. Dr. Rotow, we really appreciate it, and we look forward to hearing from you in the future.
Great. Thanks so much.